right now. We will share the recording, the PowerPoints, and any resources that we mentioned during this webinar on our YouTube channel, and I will also send that to all the attendees and everyone who has registered after this webinar. Today's webinar, we're excited to present on brain health and trauma among people with intellectual and developmental disability, systemic bias and ableism in healthcare. A little bit about today's webinar. Accessing culturally relevant trauma-informed care is a major challenge for people with intellectual disability. Healthcare providers, social service providers, and community supports may have biases about people with disability that interfere with their ability to provide culturally acceptable care. This webinar examines historical perspectives on ableism and disability bias and reviews the impact of ableism in healthcare for people with intellectual disability through case-based learning. We will discuss key approaches, including trauma-informed care, to support people with intellectual disability who experience sexual trauma. We have amazing presenters today. Leanne Davis, I will let each presenter introduce themselves, as they can speak about themselves better than I can read the bios. Jamie Suvak, Patty Quiteri, and Kecia Weller. Leanne?
Thank you so much for that quick kind of setting up for our webinar series. I'm Leanne Davis. I'm the Senior Director for the ARC's National Center on Criminal Justice and Disability, and so happy to be here today to bring this webinar series to you, working with the Board Resource Center and with our wonderful partners with the HealthMatters program as well. So I wanted to just give you a little bit of an overview of our National Center on Criminal Justice and Disability. The center was created in 2013 and we're funded through the Bureau of Justice Assistance. And our goal is to really advocate at that intersection of criminal justice reform while also advancing disability rights. We work on both victims issues as well as those that are suspects in the criminal justice system. We have a broad portfolio of work that we do at the center that includes funding through the federal government as well as foundations, and have a small but mighty staff working on these issues. We work to really reach out to disability advocates as well as criminal justice professionals, people with IDD, and our over 600 chapter network. Some of the key items that we do through the center is provide training and technical assistance. Next slide, sorry about that. We provide training and technical assistance as well as information and referral, a number of different policy briefs and other publications, all seeking to educate folks through social media, webinars, and attending different conferences. Next slide. And I just wanted to mention a few of our projects here so you'll get an idea of the different work that we've been doing since starting about 10 years ago. In fact, we'll have a 10-year anniversary this year. We're working to develop a national training for law enforcement that looks at people with mental health as well as intellectual developmental disabilities. I just wanted to mention that we are using IDD for short. So if you see that on the slide, that's referring to intellectual developmental disability. We also have a project where the project is looking at how people with autism, especially children, wander, and how we can provide education and prevention of children dying due to that. Key projects that relate to our topic today is on violence and trauma in the lives of people with IDD. We have a project working with the Board Resource Center and Kecia Weller, who you will meet soon, called Talk About Sexual Violence, where we're educating healthcare providers about how they can talk to their patients that have intellectual developmental disability, specifically about sexual violence. We are providing strategic planning in Arizona for their statewide network on this topic. We also do some international work through the Open Society Foundation, have different contracts, and provide a community of practice for our chapter network on issues related to criminal justice. Next slide, please. So let's talk about the series and talk a little bit more about specifically this interconnection between brain health and trauma. The big thing we want to ask is what is the connection and how does that impact healthcare professionals? What are the key messages do we need to be bringing to the healthcare profession when we think about this issue? Well, first of all, individuals in the medical profession need to understand that there is a disproportionate impact, a large impact of trauma among people with IDD across their lifespan. We did note some of the places to find data on this topic here below that key phrase. So people with IDD of all ages are more likely to experience trauma compared to their peers without disabilities. There's also a higher risk of maltreatment for people with IDD, and that increases the risk of trauma throughout their lives. This trauma could include emotional, physical, sexual abuse, neglect, and exploitation. Um, some of this data comes through the Bureau of Justice Statistics. We do have, federal data that can provide this information. When I started out in the field 27 years ago, we did not have this data. So it's important that we continue to advocate through federal surveys such as the National Crime Victim Survey to really include people with IDD in research and surveys like this. Secondly, we know that trauma and resilience informed healthcare systems can improve three different areas. So we're thinking about healthcare engagement. So how do people in the medical field engage, interact with people with disabilities? Do they have the skill set that they need to do that? Treatment involvement. How are people with disabilities involved in their own treatment? And we often talk about supported decision making and self-determination and really giving people with disabilities the tools they need to have the kind of communication that is effective with their healthcare professionals. And then, of course, all of this can positively impact health outcome. So it's important to link these three together and think about how all of these interact. And that's what we'll be talking about today in the webinar. Next slide. I wanted to mention too that a good precursor to this series, if you'd like to go check this out, is a webinar that we provided in 2021 as part of the Healthy Brain webinar series. It was called Preventing Violence, Abuse, Neglect, and Exploitation of People with IDD. It includes the webinar recording. You can check out the PowerPoints and links to a number of different resources through that webinar. That webinar, we really looked at identifying the different range of abuse and neglect that people with IDD experience, and then learning how to talk to people with IDD about trauma. And that was focused on healthcare providers as well. And you can check out that link, and I think that that will be put in the chat as well there for the HealthMatters YouTube channel. So with that as a background and thinking about what we talked about, the link between brain health and trauma and people with IDD, let's hone in on what is the purpose of this series. So this is the first of 4 different webinars that we'll be bringing you. So the key purpose is to highlight those discriminatory practices and that implicit bias that's in healthcare settings and encourage the use of trauma-informed care strategies. We have to address the bias. And, working from a National Center on Criminal Justice, we see similar biases, right, among law enforcement as well, among courts. And we also see it in the medical field. So we want to really highlight this so that we can help healthcare professionals understand that when they see their own bias, they can better address that and provide more trauma-informed care responses, right? And more strategies that they have in their toolbox when they're working with the disability community. And a key point to this, and we want to thank so much the work of Patty and of Kecia, of people who are peer advocates, survivors, who are really bringing the message home, for the healthcare community. We want to learn from you and healthcare providers about brain health and trauma-informed care. So we'll be hearing from both Patty and Kecia here in a few minutes about that. Next slide. So I will provide just an overview of what we'll be talking about on today's webinar. As I already mentioned, that trauma affects people with IDD throughout their lives and as they age. And to keep that in mind too, that it's not, it's really throughout the lifespan of someone with IDD. And then also that accessing trauma-informed care is a major challenge for people with IDD. So thinking about what are the barriers around that. Healthcare providers, social service providers, and community supports may have biases about people with disability that actually impacts their ability to provide acceptable care. So where is that implicit bias really keeping people with disabilities from getting the help that they need, from being able to communicate even with their healthcare providers? And then we also reviewed the impact of ableism in healthcare for people with IDD through case-based learning. And we'll do that through the Talk About Sexual Violence project, which has created videos, which some of you already had a chance to watch. If you didn't, we really encourage you to go back and watch those videos. But these really bring case-based scenarios to the work, and we think that that will help in terms of bringing some key messages home for those watching the webinar today. Next slide, please. We wanted to start off too with the same definition of trauma across the board, and we all have the same idea in our minds when we're thinking about what does trauma mean. So we are using the definition from the Substance Abuse Mental Health Services Administration, also called SAMHSA because it's so long and hard to say. So from SAMHSA, we get these three key items that make up the definition of trauma. First of all, it can result from an event, a series of events, or a set of circumstances as physically or emotionally harmful or that is life-threatening. So we're looking at what caused the trauma. Secondly, it has lasting adverse effects on the person's functioning and their mental, physical, social, emotional, or spiritual well-being. So not only is it what it's from, but what it causes. And then thirdly, it can affect the brain and the body, which can cause some of these different types of outcomes, including behavioral, physical, sleeping issues, and increased risk of developing dementia. So this is not all the different effects, because there are many others, but this is just providing some examples of what trauma can cause. Next slide, please. And something we also wanted to really help listeners keep in mind, and as you think about the rest of the series too, to keep this in mind, that we know the impact of trauma is widespread. So when we think about brain health, right, we have to think about how trauma is impacting folks in all of these different areas, and we think about the lifespan as well. So some of the areas to keep in mind are in these three different buckets, from abuse, which can be physical, emotional, sexual, as examples, to neglect, and also just general dysfunction that's happening in the home. So these, just kind of keeping this in mind, that this can affect people in many different areas, and thinking about how this affects people with IDD specifically in these different buckets as we look at the link between brain health and trauma throughout the series. Next slide, please. So this leads us to the Talk About Sexual Violence project, which I just mentioned earlier. What this project has done is create easy to use training tools for healthcare providers, one of which you already saw if you watched the video. Our goal is to really create easy, quick, not too long videos and quick, easy to use information for healthcare providers to help them know how to comfortably have conversations about really hard conversations to usually have with people with IDD. We're outreaching to healthcare providers in a number of different avenues, one of which is webinars like this. We hope to increase those patient-centered conversations so that the focus is on the patient with IDD, that will also help increase reporting of sexual violence and just generally decrease discomfort that healthcare providers can feel because they've never been able to practice this or know how to do it before. I wanted to mention that there is a QR code that you can use to quickly go to the project more easily on your computers. And then next slide. As part of this project, there are some core values that we think is very important. And we can think about this as it relates to any type of trauma that people with disabilities may experience. But the two that we see, that we hear from people with disabilities often, is that they want to be heard. Listen to us. Take time in the appointment to listen to us. And then secondly, believe. How important is it, and how easily sometimes, especially if there's a doctor in the room or a healthcare provider in the room, and then the care provider, for that individual to talk to the care provider, for example, instead of the person with a disability. So while that might not seem like a big deal to those in the medical profession or who don't live in the disability community, that is a huge deal. The person with a disability can feel completely dismissed. So that listening piece and that believing piece is core to talking about sexual violence and other types of trauma. And we just provided here again an example of James going to the doctor as one video that really addresses the issue of stereotypes that men aren't abused when they are. So James really wanted to bring this out in the project. And then secondly, Kecia's video highlights how to be clear with your doctor about abuse. And she has her own life experience to share on that, which she will do here in a few minutes. Next slide. So what is the call to action from National Survivor Leaders? First of all, Kecia mentions that we need to talk about sexual violence to end this silent epidemic of abuse. And then James focuses on the fact that people with disabilities deserve to live a life free from abuse. And then too often it's ignored or excused. So key messages that we really want to help to promote in any way possible to the healthcare profession. Next slide. And I will hand it over now to Jasmina, who will present Kecia's case as our moderator today. And thank you so much, Jasmina, for walking us through this specific scenario. And I know that you'll be able to provide a question at the end, and hopefully we can hear from folks in the chat about that question.
Thanks, Leanne. I have already emailed. We cannot watch the videos because everyone has different internet speeds, so it gets really frustrating to watch the video in a live format. So I've provided I'm going to provide a link to Kecia Meets with her doctor video again. I know some of you or many of you have watched it already before the webinar, and I thank you for that. It's about 3.5 minutes. And the purpose of the video is, in this 3.5 minute video, is where Kecia meets with her healthcare provider. And the video illustrates a medical appointment where Kecia visits with the doctor and discloses that she has recently experienced sexual violence. The doctor and the nurse had gentle tones to their voices and made eye contact with Kecia. They were genuinely concerned about Kecia's bruised arm and infection. The doctor asked Kecia's caregiver to step outside the examination room. The doctor used the picture chart to help Kecia articulate where she had gotten abused or hurt. And even though Kecia was traumatized, she did not appear re-victimized by her doctor's visit. And both the doctor and the nurse used everyday language so Kecia could understand what was going on. At the end, they followed up and asked told Kecia that there are people that can help her. So the question for you posed, and please put your comments in the chat box, is what would you do to promote continuity of care after this doctor's visit? And as a definition for the continuity of care, it's an organized and carefully coordinated process that's essential to high quality patient-client care, which involves the patient family and an interdisciplinary team working together to facilitate the transition of the patient-client from one level of care to another. So if you have any comments about what would you do next to promote this continuity of care, please put them in the chat box. I'm seeing some already. One of the questions, if we were to conduct training to our own agencies, are we able to use these videos? I'm going to let Leanne answer that. They are available on YouTube, so they're public.
Absolutely, yes.
Okay, great.
Please use them. That is the whole goal of the project, is that they are, and they're quick, right? They're quick and easy to use. We also have other um, different publications that are very easy and simple to use as well, like charts, different things on our website that go along with the videos. So please check all those out, and you can contact us directly if you have more questions about that.
And don't worry about grabbing these video links or anything. We will post everything on the YouTube channel, and all of the links and resources will be available to you, and you will be emailed once that's up. And it usually takes less than 7 days for us to do that. So just sit back and just listen in and soak in as much as you can. One of the comments, provide follow-up with both the patient and her caregiver, ensure her family and guardian, if appointed, are aware of the appointment. And then Leanne, Mark, Kecia, or anyone else of the presenters, if you want to jump in and kind of do a commentary on this, please do. Another attendee mentioned you create an aftercare plan. This is best done by a therapist, but agencies can create an aftercare plan that is helpful. A warm handoff to social work would be good. I also think it'd be valuable in the videos to at least have the dialogue that the victim is no longer at risk, safe from the perpetrator.
That's a good point.
Ensure that Kecia understands the next steps and ask if she wants support and who she wants to support her. I would ensure that she was set up with a therapist and that staff working with her are educated on trauma and understand what could develop from this trauma. Follow up with her. The perpetrator needs to be investigated. Next steps should include this. Involve adult protective services. Any comments so far? I'm reposting the video link for some of you asked for it again.
I think these are wonderful. Thank you so much for everyone for posting these. We're actually going to go back and look at these as a team, as these are great. I will say that even just getting a therapist who know how or have expertise working with people with IDD can be challenging at times.
Oh yeah, that's true.
So that's one of the things that that I hear from different places throughout the country, of just finding individuals that have that expertise or are willing to do that. I also see a comment about involving adult protective services, and that is, of course, one area that we have been doing quite a bit of work at the national level in ensuring that APS does address this issue, that they're focused on people with disabilities too, with with the work that they do, because we've often heard that hasn't always been there, and that the APS has not always been responsive. So there's some really good points, I think, that as the webinar continues, that we can kind of circle back to some of these comments that have been made. So thank you so much.
Thanks, Leanne. And next, I wanted to introduce Jamie, Patty, and Kecia, and they will be further talking about trauma-informed approach. Jamie?
Thank you. And thank you for having us here today. It was funny because my daughter was asking me, Mom, are you nervous about this big webinar today? And I hadn't thought about it because I'm just so passionate about this work and excited to share what we've been working on with all of you in hopes of creating further change. So thank you all for being here with us today. My name is Jamie Suvak, and even though This slide is a little bit off. I'm actually a PhD student, so I want to be clear. I don't have those letters quite yet. And I'm at the School for Global Inclusion and Social Development at UMass Boston. I formerly was at the Disabled Persons Protection Commission in Massachusetts, and I helped to start the Sexual Assault Response Unit, which employs peer support leaders as well as navigators to increase access to trauma services for survivors with disabilities. I'm also a licensed mental health counselor, and I've been working in the field of therapy, advocacy, activism, education in sexual violence for about 25 years now. And I would really love it if Patty introduced herself and then Kecia introduced herself as well.
I'm Patty Quartieri. I am in Massachusetts for Disabled Person Protection Commission. I used to work with Jamie very well, and I do a lot of work. So this is my passion. I've been doing this sexual assault for 35 years, and trying to start in groups south and in 90s. Thank you. Thank you. Remind me.
Hello, everyone. My name is Kecia and I am the national co-chair with my colleague Patty Kotori for the Peer Support Network, and I've also worked with Jamie Subak for a bit through the Peer Support Network. I have also been working with the National ARC, the National Center for Criminal Justice and Disability Center with Leanne Davis, and the Board Resource Center with Mark Starford on talking about sexual violence projects for quite a few years. This is our third grant, and I'm really happy about that, from the West Foundation. I am also a co-founding member of the California Silence Equal Violence Coalition Network. So it's a pleasure to be here, and this kind of work is my passion. I don't even get nervous when I'm talking about it.
Thank you, Patty and Kecia. And before we jump in, I was hoping that if folks could think about the words trauma informed and just put in the chat one word or two words that come to mind when someone talks to you about trauma informed. I'd like to know what folks are thinking when they hear that word. And as you're doing it, I just want to remind folks that we're going to be hearing some personal stories. We're going to be hearing about some trauma. We're going to be hearing about some experiences firsthand, and that sometimes can be difficult. And if you are having a hard time, do what you need to do. Take care of yourselves, to step away, but please come back to us at some point. I also want to just let you know that we're going to be doing a very brief overview of trauma-informed care and trauma-informed approaches, but then we're really going to be talking with Patty and Kecia about their experiences and how it exemplifies some of the things that have been going well and been changing, nice, and some of the things that have not been going so well for them, and the work that we need to continue to do. One thing I want to make very clear is that Patty, myself, and Kecia have been working very, very hard on this presentation to make sure that what Patty and Kecia would like to say gets in this room, in this webinar today. So what you might notice is that I have my notes from when we've been meeting and the things that Patty and Kecia have talked about in our meetings and put together for themselves. And you might see me prompt certain things based on things we've talked about, but I want to assure you that these are Patty and Kecia's words, their thoughts, and the things that they want to tell you today. I also want to let you know that if you have questions, you can feel free to put them in the chat, because we're really hoping to have time at the end of this. And Patty and Kecia said they're both open and they're ready and willing to answer any questions that you might have for them. So that being said, we can move to the next slide, please. And I'm going to scroll up and see if what folks have said here on the chat, listening and caring, very real, compassionate listening and presence, understanding that many people experience trauma, require understanding and compassion, how best to interact with folks, recognizing lived experience. Oh, I love these. First person first, knowledgeable and thoughtful about trauma. Yeah, these are amazing. Oh, these are great. So yeah, there you all are very well versed in trauma informed and what it means on the interpersonal level. So from how to work with a person one-on-one or in a group. And those things really rely on these 6 principles of the trauma informed approach. They rely on safety. And safety is not just physical safety. It's very important for folks to feel safe, and that means to feel like they're being listened to, that they're being understood, and that you're going to take care with what they're telling you. And both Patty and Kecia will talk in their interviews with me about all of these principles in one way or another. It's also about trustworthiness and transparency. I think sometimes especially with trauma survivors and especially with folks with IDD, we're afraid to tell them the truth. We're afraid to tell them the realities. We're afraid to give them the decision-making opportunities. And those things are detrimental to the trauma-informed approach and the trauma-informed care that we all want to give. Peer support. This is something I am a huge advocate for, and I've seen the magic of it over and over again, because it really does do a few things. It really does create this idea of shame defiance. You know, I am in the room with you. I am a survivor. This is not something to be ashamed of, and we can work on this together. And also in this idea of strength dealing, that I'm going to share with you some of the things that I have done in my community, in my life, that I understand where you're coming from, and I can share my strength with you. Collaboration and mutuality. This really is a broader concept. It's about not just moving in a multidisciplinary fashion, but really transcending that into a new way of being and working together. That's not only
I
in
just remembered.
our own disciplines. Empowerment, voice, and choice. We will hear a ton about this today. And then really thinking about communities and people as part of a larger culture, as a part of our own society, and all of the different ways in which different communities and marginalized populations have been affected, not just by having a disability and having an act of sexual violence, but in everyday life for other reasons. So the intersectionality of life is really what we're talking about. Next slide, please. So one of the things that I noticed in this chat today is that everybody did an amazing job with talking about that one-on-one interaction. How do you work with somebody who has experienced trauma in a trauma-informed way? And you have written all of those things down in this chat. But the one thing that I would challenge you to do is say, where do those behaviors come from in our work? They come from our policies and our procedures of our agencies, the things that rule how we do our work. So if you're great one-on-one and you know what you need to do, those things need to go right up that chain, and they need to be put into procedure and put into policy so that it's standardized, it's consistent, and it's ensured. By that happening, you can then train all staff existing and folks that are coming in new on the trauma-informed care that is so desperately needed. Some other things that are really important are screening for trauma. We heard Leanne talk about the statistics earlier in this webinar. This is a huge epidemic. We need to understand that this is happening to people with IDD at astonishing rates. And so it's something that should be in our everyday language, in how we're working with people, in our professionalism, in our intakes. It should be part of our repertoire. It should be part of our conversations all the time. We need to build relationships. So it's not, and a lot of the folks on this chat said in the beginning, what would be the continuity of care? And they talked about follow-up, warm handoffs to social workers, trauma-informed care and therapy. Those things can't happen in this world without relationships. I have been in the field of mental health for a number of years, and I can tell you, especially right now, professionals are overloaded. So we need to really think about who and how we can work with our communities so that we can make sure that there is someone to do a warm handoff to, that there is somebody that we trust and that we can say, this is a good person to work with and they will help you. And then I think one of the biggest things that I want to talk about is engaging trauma survivors in all aspects of the work as leaders. And I think that's a very different perspective than as participants. What I have experienced personally and professionally over the last few years is that it is imperative, it is essential, it is necessary for the folks who have experienced sexual violence, who have a disability, to be telling us how to fix this, how to move forward, and how to do a better job, because that is where we get the best information and can create the best change. So that is what we are going to move on to next, which is actually hearing from Patty and Kecia about their experiences and how we can all do better. So in the next part here, I just want to remind folks, I know I said it once, but it's so important for everybody to truly understand that these are all Kecia's thoughts. They're all what she wanted to talk to you about today. And if you hear me prompting, it's something we've already talked about and discussed and how we want to work together. And I have my list of notes, Kecia, so I'm ready to interview you about your experiences. Are you ready? I didn't hear you. Are you on mute?
Yeah, I'm definitely ready.
Okay. So, Kecia, can you first start by talking a little bit about the doctor's appointment that was described?
Yes, in the case scenario, one of the things that the doctor and nurse did for me was they had gentle tones in their voice, and so like they weren't high pitched or low pitched. They were gentle tones. They also made eye contact with me, which I really appreciate, because they're saying to me, "Look, Kecia, I value you as a person." And they showed compassion towards me. Both the doctor and nurse did, about the bruise on my arm and my infection. And in addition, I really like the fact that they also used everyday language. They so that they didn't like, if I have a urinary tract infection, they did say to me, "Well, let's hear about your UTI right now." They explained everything else, and it's great. And I just want to say that in terms of plain language and everyday language, on the Talk About Sexual Violence website, I also have a plain language webinar where I talk about how important it is to use plain language.
And Kecia, have you found that that's not like a regular thing with doctors using plain language?
No, typically no, because I even when I go to my regular doctor for something else except for besides sexual assault, I often hear from my peers, other people with IDD, saying that they don't understand their doctors very well because they use these big medical words, and so it's very valuable for all healthcare providers to use everyday language with us when we go to their appointments.
And I have to tell you, Kecia, that I learned that from you in doing this work, in so much that I had my own doctor's appointment this week. And I actually said to my doctor, because I've heard you say this, and I advocated for myself, and I said, can you show me, it was about my spine. So I said, can you show me a picture of what you're talking about? Can you tell me what those words mean? And I was thinking about you at the time because it's something that I learned from you.
Right, exactly. Like in a recent medical appointment, I just broke my collarbone, and I had my doctor show me the X-ray with my broken collarbone, so I understood what the break was.
Yeah, exactly. So the video that you made, you talk about the things that the professionals did well and what stood out and what made you feel cared for. What was your real life doctor's appointment like?
Well, my real life doctor appointment was a stark contrast to the video doctor's appointment. Like like for example, my real doctor's appointment, he kept on asking me rapid questions, and
Too fast.
he felt nervous to talk to me about the sexual assault, and he kept on fumbling his words. Also, one of the main things that really distressed me, it made me feel invisible and very uncomfortable, is that when we first entered the room, he was addressing all his questions about what happened to me to my support staff, and that totally made me invisible, and it made me feel more anxious. It was so disappointing to me when he did that. And other thing is that when I was talking to him, he told his nonverbal communication told me that he didn't believe me, that I had actually been sexually assaulted, and being in a lot of the questions he was asking me, I didn't understand because he was not talking everyday language.
So when you think about the video that you made on the what I would say was a ideal appointment, things that they did really well, and the appointment that you actually had in real life, what was the difference?
The difference, the contrast was starking, because the contrast between the two visits, like the video doctor actually showed me compassion about what I was going through. He understood the sexual trauma. My real doctor, he didn't. I can't pick up any empathy or any compassion to how he was treating me. He was treating me like a less human being. My real doctor was treating me like I was not human. But the video doctor was treating me as I was a human being, showing me compassion, and he also used picture chart to help me articulate where I had been abused. Like in the video scenario, I actually showed him my vagina because I was raped, and also my arm because it was bruised. And in my real life doctor, he didn't do that at all. And I couldn't articulate why I had been where I had been abused because of the trauma.
So it prevented you from being able to tell somebody what happened.
Exactly. That's very true.
Okay. So I'm getting a note that there's 5 minutes left. Okay, so
Oh my God.
yes, that went very quickly. So I think I'm going to move on to Patty, so we can give Patty a little bit of time. But thank you so much.
Sounds good.
Kecia.
Thanks a lot, Jamie.
Thank you. So Patty, Can
Yes,
we talk a little bit about what it was like when you reported the abuse to your doctor?
I went to the doctors by myself. I like my doctor, and he listened and he talked to me. I was living in group home. I was dropped off, and I was in the room alone. I didn't tell my doctor everything that happened. I was scared. After nothing changed, I went to work. I went to therapy. She helped me.
And do you feel like you were treated in a different way because of your disabilities?
Professor did not know what to do with me. They thought my anger and flashbacks were because of my disability, not trauma. They thought I could not understand what happened. They did not use everyday words. Many people did not believe me. I feel really alone.
And then what happened after your appointment?
One day I had a flashback about myself. I attempted suicide. I was brought to the hospital for 5 months. They did not know how to help me. Was I trained in my own room? I was angry and I act angry. They put me in a group home, not paid attention to the trauma. Finally, I stood up for myself and I got my own place.
I love that part.
Thank you.
And did you get the help that you needed?
Not right away. They didn't understand trauma and did not know the resources I need. Until I got resources because the court was involved.
Thank you, Patty. Thank
Welcome.
you for sharing that. So in the interest of time, we're going to move back to looking at what recommendations that Patty and Kecia have based on their experiences, both for themselves and then as peer advocates. So Kecia, what would you advocate for?
I would definitely advocate for using trauma-informed practices, treating for health care on the needs of people with disabilities, spending more time with the survivor, definitely, because that's very important. Being patient because it's hard to talk about sexual assault, especially for the survivor who has trauma. Having resources available that are easy to understand for the survivor, and using teach back at the end of the appointment. Teach back is basically when the healthcare provider asks the survivor, what do you understand what we just discussed in this appointment? The survivor then will paraphrase what had happened in the appointment, and the healthcare provider will say, yes, that's correct, or we need to work on some things for you to have better understanding.
Excellent. And Patty, what is better now?
But advocacy, survivors speak up. We been getting heard. We start a national network. Healthcare. This is the same nurse in the ER room. More training for the doctors, more trauma-informed therapists, APS. They are learning about how to work with us, public. More information is in the news. People are learning how often it happens.
Thank you.
Welcome.
Next slide, please. And the next slide, please. Okay. So, Kecia, let's start with you. Ways healthcare can improve. What do you think?
Oh, very much so. I'm passionate about this topic. The first thing is listen to the survivor and be patient. But a very good one is believe them, because most people they know that when their implicit bias says if the person has a disability, they don't automatically believe them that they've been sexually assaulted. Also, remind the patient what is important to do before they leave the appointment, which goes back to the teach back.
Thank you. And Patty?
Learn about trauma-informed practice and use them as if the person feels safe before the appointment ends.
Thank you.
Welcome.
So we know we're going to move to questions. Patty and Kecia, I mean, I could hear you talk about this all day. I always learn something new. So thank you for doing this with me today. And what I really hear in this part of your presentation is that how people interact with you is just as important as what they're doing. The how is just as important as the what. And that's something that I think we can all take away today from your experiences. And as well as taking the time to really make sure that you understand what they're saying and they understand what you're saying. And that's just good practice to make sure that you've been able to tell what you need to tell and you understand what the professional has told you. So I think that those are some big things that I took away. And as a trauma-informed approach, those are things that prevent re-victimization, which you both talk about being re-victimized by a system after being victimized by a perpetrator. And that's really what we want to avoid, because that created a lot more problems for you and prevented you from healing after the assault and after the violence. So thank you so much for sharing that with all of us today. And we do have a couple minutes if there are some questions.
Thank you so much, Kecia, Patty, and Jamie. I'm getting some questions in the chat. One of the things that I actually noticed that it came as a comment in the beginning of the presentation was someone said, I feel like trauma-informed is often said, but not as often fully defined or described how you operationalize it. And I think a lot of the questions that are coming through are actually, how are we going to operationalize what we are covering today? And hopefully webinar 2, 3, and 4 are going to come into the play and talk about operationalizing what we are just starting to mention and talk about today. So do any of you care to comment on that? Or I can even start kind of asking some of these questions even further. Do you have any best practice examples of health education materials that work well for people with intellectual disabilities, for example?
Patty or Kecia, do you have any examples that you like?
Examples of what, Jamie?
Health education or any kind of education about relationships, healthy relationships?
Well, in terms of health education, I do know that it'll be beneficial for for medical students to get this to how to be trauma informed in their medical schools, and actually how to work with people with disabilities in the first place. Because I know from experience that medical schools don't offer this. They get education in different diseases or stuff like that. But when it comes to talking with people with disabilities, many doctors don't even know how to approach the subject. And so I think that we need medical school curriculum to touch on this.
Yeah, that's a great point. I do know that there are some resources, and maybe that's something we could put together and send out in an email later. Because I know some local ones, but I'm sure we could get something across the board.
Thank you.
Jamie,
Oh,
I wanted to just pipe in and say, in Arizona, where we've been working, they have started an online support group for folks. So, and it's for people nationally. So it's not just in their state. And I'm thinking that might be another way to help people and to find peers and to really kind of build that. And of course, the National Peer Support Project as well is a good resource. But I'm just going to I just put their website in the chat. And this is fairly new what they're doing there to provide that online support group. So that's another possibility.
thanks, Leanne. Couple of other questions that have come through. Do you have any words of encouragement to assist support staff in advocating to the legal guardian on behalf of the individual if the individual is not able to be heard? I have crossed many experiences where the individual wants to process their trauma and heal from it, and the guardian may decline to listen to the survivor and believe their truth and support the resources the individual needs.
So at the sexual assault response unit, we came across this a lot. And really what we found was attending to the needs of the guardian and finding out more about what was going on for them really did help open the pathway to then allow to help the survivor, and really having them understand what the plan was and what it wasn't as far as looking at trauma or healing from trauma. Because I do think people have an idea in their mind of what it would look like, and it's not always the case. So really walking them through that and using practical and simple language to help them understand it is a huge thing. And then I think the other piece of it is some education around ways in which healing can help that person maybe prevent some behaviors that they're doing that seem unhealthy. Because I think that's in working with folks with disabilities, a lot of times the language is around behavior. So using language that people know makes a big difference.
Thank you. One of the comments, one other thing I found so important in the video was how the doctor opened and guided the conversation. I presume this is important trauma-informed and responsive training. So important to have this presentation today. I greatly appreciate this panel of experts and the preparation you all took to share this important information. Thank you, Maria. We're really hoping that some of these operationalizing trauma-informed care and then being able to describe healthcare provider roles, talk about signs and symptoms of abuse and neglect and exploitation and other trauma will be covered on March 8th webinar. So I hope everyone can join. If not, we are recording that webinar too. You can register still, and we will email you once that webinar has been recorded. We are at the hour. Thank you so much for attending today's webinar. Like I said, all the PowerPoints, all the resources that we've mentioned today and the recording will be made available and you will be emailed. Thank you. Thank you to all the presenters for sharing and presenting on today's webinar. Have a great day, the rest of you. Thank you so much. and goodbye.